Hi, you guys. Welcome back for our daily practice questions. It is day 67, and as always, I like to first start with my introduction and disclaimer before getting started with our questions for today. So, for those of you who are familiar with me, hey y'all. For those of you who are new here, welcome, welcome, welcome. I am Dr. Brittany Weinstock, and I'm a family nurse practitioner and the founder and CEO of the Nursing Studio. I provide resources, tools, review courses, review videos, Q banks, digital flashcards, one on one sessions, and more to assist nurses as well as nurse practitioners with success on their boards as well as in practice. I've been doing this since 2015, assisting nurses and nurse practitioners internationally with exam success. But y'all know my disclaimer and reminder that we know there's no absolutes in medicine. We treat on a patient by patient basis, and any of the questions that you see here, I have designed and created based on the current guidelines that are being tested on the ANCC as well as AANP exam. Now, any of my videos where I'm teaching on things that we currently do in practice, I will always say that so there's no confusion. So, with that being said, let's get into question number one for today. All right, you guys, and if you are looking to enroll in the upcoming 5 week review that starts April 21st and runs through May 30th, grab your spot. There are 4 spaces available. And let's get into our questions. Question number one states a 52-year-old woman presents to your office with a 24-hour history of right upper quadrant pain, nausea, and vomiting. She has a fever of 101 degrees. On exam, she has tenderness in the right upper quadrant and a positive Murphy sign. She has a history of occasional indigestion, but has not been diagnosed with gallstones. Based on your clinical assessment, you suspect acute cholecystitis. What is the most appropriate next step in treatment for this patient in the office setting? Is it A, administer IV fluids and analgesia only and schedule a follow-up appointment? B, refer immediately for lap chole? C, prescribe antibiotics, symptomatic management, and refer the patient to GI? Or D, perform an abdominal CT scan to confirm the diagnosis and then refer to surgery? Take a moment and tell me what you got, y'all. All right, so I always recommend reading the stem of the question first, as it allows you to slow down to ensure you're answering what is even being asked of you. So here, the stem of the question states, what is the most appropriate next step in treatment for this patient in the office setting? So, okay, we're talking treatment. And I always tell y'all, if it's a treatment question, look to see if they have provided you with the diagnosis. If they have, then you proceed, right? But if they have not, then you need to take it a step further and run it back to see the assessment findings, because you got to know what it is to be able to treat it. Here, they're saying acute cholecystitis, right? So, how do we treat cholecystitis? So, your best answer is C. You can prescribe antibiotics and symptomatic management, and then you want to refer them out to GI. So, GI can do further evaluation. If there is surgical repair that is required, they will be the ones to do that. Remember, don't get caught up in what you know the next steps will be. And what I mean by that, my history, I've always worked in acute care as a nurse, but as a family nurse practitioner, you have to redirect your mind. So even though I know that GI may take these steps, or we may start to do advanced things that are considered symptomatic management until GI can make their rounds to see them, you're not doing that in the office. So make sure I always say, think of the patient that they're standing in front of you in the office so that you can adequately walk through what you would do in that case and then refer, right? So we're going to refer out. You can give them the symptomatic management to help cover them in this current state, but you are actively referring for the further management. So C is your best answer. Question number two, a 25-year-old male presents with a 12-hour history of abdominal pain that started around the umbilicus and now is localized to the right lower quadrant. He is febrile with a temperature of 101 degrees, and his white blood cell count is mildly elevated. On exam, he has rebound tenderness and a positive Rothstein sign. Based on your clinical findings, you suspect acute appendicitis. What is the most appropriate next step in managing this patient in the office? Is it A, to perform a thorough abdominal exam and prescribe antibiotics, then schedule a follow-up in 2 weeks? B, refer for immediate surgical management? C, perform a CT scan of the abdomen and consider observation for 24 hours? Or D, prescribe a pain management regimen and monitor the patient for a few days? Take a moment and tell me what you got, y'all. All right, so stem of the question, what is the most appropriate next step in managing this patient in the office? All right, so what are we talking about? We have a patient with acute appendicitis. And again, when they ask you next step in management, we are still talking treatment. So you're still going to run it through the same way. Don't let change of wording change your approach. Okay. So just because they use next steps in management, it still means treatment, right? So look to see if there is a diagnosis provided, which it is acute appendicitis. And then you work your way through with how you treat, right? So in this scenario, we would refer for immediate surgical management. Um, because if it's appendicitis, they need to do the appendectomy. There's nothing we can really do at this point in the office other than some symptomatic management. But if they are warranting any further scans or treatment, that surgical team would be the one who deems all of those things that are necessary versus you trying to figure all that out in the office. Okay. So refer, refer, refer. And then lastly, question number 3. A 40-year-old male presents with severe epigastric pain radiating to his back, nausea and vomiting, which started after drinking alcohol the previous evening. He has a history of heavy alcohol consumption. His vital signs show mild tachycardia, and his abdomen is tender to palpation in the epigastric region. His amylase and lipase levels are elevated. Based on your finding, you suspect acute pancreatitis. What is the most appropriate initial management for this patient in the office setting? And I'm going to read that one more time. So we have a 40-year-old male presents with severe epigastric pain that radiates to his back with nausea and vomiting. And this started after drinking alcohol the previous evening. He has a history of heavy alcohol consumption. His vital signs show mild tachycardia, and his abdomen is tender to palpation in the epigastric region. His amylase and lipase levels are elevated. Based on your findings, you suspect acute pancreatitis. What is the most appropriate initial management for this patient in the office setting? It's A, administer symptomatic management, then refer to the hospital for further management. B, prescribe oral pain medication and instruct the patient to follow up in 48 hours. C, start IV antibiotics and refer the patient for surgical consult. Or D, initiate oral rehydration therapy and monitor in the office for 2 to 3 hours. Take a moment and tell me what you got, y'all. All right, so similar question. What is the most appropriate initial management for this patient in the office setting? So again, treatment. What are we treating? And it says acute pancreatitis, right? So what are you going to do for acute pancreatitis? And the best answer here in the office setting, you would A, administer symptomatic management and refer them to the hospital for further management, right? Because again, you're going to treat what you can and refer them out for management and any additional treatment that may be warranted. Some offices, I know you may do some IVs in some office settings, but remember, for board's purposes, think of the perfect scenario. Everything is just how it's textbook, so to speak. So don't tell me what you think or what you have done at certain practices or things like that. The test is not testing on the outliers. Think about the things that are textbook. So you're not going down the rabbit hole and creating additional storylines because it's going to cause you to get it incorrect. Okay. So just picture the textbook office setting and the things that you can actually do in that setting, okay? Staying within the scope. All right, you guys, I hope you found this helpful. As always, be sure to like, comment, subscribe, and share with whomever you may think may find this beneficial as well. But y'all know what to do. Y'all make sure y'all meet me back here. And if you need any of the resources that I do offer, feel free to reach out to the Nursing Studio by giving us a call at 803-400-6864. You can also shoot a text message to this number or shoot us an email to the nursing studio, the number 1 at gmail.com. Everything that I do offer is linked in the bio of this channel, including my website. And if you're looking to book any of my one-on-one sessions or any of my custom packages or plans, I always say either call, text, or email so that I can speak with you first because I prefer to gauge what you truly need to make sure you're booking the appropriate session type. All right, you guys. Y'all know what to do. Y'all make sure y'all meet me back here. Happy studying. Bye.